Welcome back, everyone. For this lecture, we're going to continue on in the airway series by talking about hypoxia and oxygenation from the EMT basic perspective. A couple of key things to remember about oxygen. Firstly, oxygen is a drug. It's a prescribed medication. We use it to treat patients who have a specific state of disease or pathophysiology known as hypoxia or low oxygen. One of the major premises that we operate within EMS is that we're always going to give oxygen to patients who are hypoxic, period. We can assess hypoxia through physical assessment by looking at skin appearance, looking for things like pallor or cyanosis, as well as from the SpO2 side and looking at the oxygen saturation percentage. Some tissues and organs need a constant supply of oxygen to function normally. This includes the cardiovascular system and the brain. So never withhold oxygen from a patient who might benefit from it. It is a safe drug to give. There are very low side effect risks. It's a drug that we just need to be able to give when the patient needs it. With that being said, we don't need to give oxygen to patients who don't need oxygen. If you'll remember from talking in our previous lectures, we look for a saturation of oxygen percentage around or at or above 94%. If the patient has an O2 saturation of 96 or 98%, that patient doesn't necessarily need oxygen. Take a look at the equipment we use to give oxygen. In most EMS services, we use portable compressed gas cylinders of oxygen. They're noted by the green cap on top, and they can vary in sizes and shapes from the M2 all the way up to the D cells and up to the double M size, which are very, very large cylinders. Sometimes these size cylinders are maintained in an area in the truck, and that's your truck oxygen supply. Liquid oxygen is becoming more commonly used as an alternative, but it's not something we see a ton of in EMS at this time. Some things to keep in mind about oxygen. These are compressed gas cylinders, so make sure you handle them with care. Make sure that you have the appropriate pressure regulator, and we'll talk about those more here in just a minute, for the oxygen cylinder, and make sure that you're firmly attaching that pressure regulator so that there's a good seal. If there's a puncture or a hole in the tank, it can create a missile of sorts, as that compressed gas can escape rapidly and push that cylinder. So we want to make sure that we store our cylinders in a manner that prevents tipping over. So if they're standing upright in the truck, they should be strapped into place. Or if you're using them on scene and you're carrying an oxygen cylinder with you, when you lay it down, it should be laid down on its side. Make sure that we secure those so that if something does happen, we prevent injury whenever possible. Now, for the regulator for the oxygen cylinder, there are some things you need to be aware of. At least in the United States, we use a pin indexing system. It may not be the same for every country, so if you're in a different country, they may use different pins. But you can see here an image on the screen of a gas tank regulator on the left-hand side. That's with the black screw knob. And if you look inside, there are a couple of pins lined up with the plastic gasket hole there. You can see a demonstration on the bottom of oxygen is the 2,5 configuration for the pins. Nitrous oxide is the 3,5. Air is a 1,5. Carbon dioxide is a 1,6. And NTOX is a 7. This is to make sure that we're using the appropriate oxygen regulator for the appropriate gas that we'll be delivering. In our case, it's oxygen, compressed oxygen. This is more similar to the oxygen regulator you're going to see on a truck, and I'll show you some flow meters that have another picture of a regulator here in just a few minutes. But the design of the pressure regulator is to reduce the cylinder's pressure, which can be as high as 2,000 psi, or pounds per square inch, to a useful therapeutic range, and that's anywhere between 40 and 70 psi. And the final attachment for delivering the gas is either a quick connect fitting or a flow meter. You'll see a couple of flow meters here. So on the left of your screen, you'll see a hospital or a fixed mount flow meter. On the right, you'll see a portable flow meter that's attached to a regulator. In your portable oxygen containers, you'll use something similar to the solid green horizontal flow meter and pressure regulator, while in the truck or in the hospital, you'll see the flow regulators are mounted on the wall. These are so that we can adjust the flow rate of oxygen specific to our patient in need. Nasal cannulas will flow at a rate of 2 to 6 liters per minute, while non-rebreathers may flow at a rate of 10 to 25 liters per minute, depending on the indication and the use. Some additional considerations for oxygen. It is a combustible gas. While it's not truly combustible per se, it is a accelerant for combustion. It's one of the products that's needed for combustion to occur. So while oxygen itself doesn't explode, it certainly can create a significant reaction if it's introduced into a spark or into oil. So we treat it as a combustible product. So we'll treat it just like gasoline or anything else that we want to keep away from heat, flames, sparks. There's also a concept of oxygen toxicity. This had some prevalence in the early 2000s, late 90s, 1970s, 80s, and 90s, and up into the 2000s, where we can create a toxic state within a patient who's given too much oxygen. There is some credence to this, specifically in stroke patients. Excessive amounts of oxygen dissolved in solution can have a vasoconstriction effect, and we certainly don't want to constrict vessels if we're trying to get perfusion into those tissues. And this is why we talk about not overusing oxygen significantly. But we also don't want to withhold oxygen really in any circumstance where the patient is hypoxic. So with that, if a patient has a low SpO2 or is not oxygenating adequately, we're going to provide oxygen first. We may consider dialing that oxygen back to a more controlled amount once the patient is no longer hypoxic, but we're not going to concern ourselves as much with introducing toxic amounts of oxygen into a patient. Again, some of the exception there is when we talk about permissive hypoxia later in critical care instances or in the hospital, or we talk about stroke patients where we're really not wanting to excessively oxygenate them. Good rule of thumb is if they're over 94%, they're probably okay. If they're under 94% SpO2, give them oxygen. Okay. So as noted earlier, oxygen doesn't burn or explode, but it does speed up that combustion process. Keep any sources away from fire, make sure that the area is adequately ventilated, and never leave an oxygen cylinder standing without being strapped or secured unattended. And this just reiterates again about the oxygen tox. Not all patients need high concentrations of O2, especially if their SpO2 is greater than 4%. Oxygen can have detrimental effects within certain illness. So if a pulse oximetry is available, tailor that oxygen therapy to maintain a 94% or higher and try and be below that 99 to 100%. You don't need to push every molecule full of oxygen. As far as oxygen delivery equipment, we're going to use 3 predominant devices, and then we'll use some oxygen-powered devices as well in various circumstances. The 3 primary devices that we're going to use are the non-rebreather mask, the bag valve mask device, and the nasal cannula. Let's take a look at the non-rebreather mask first. The non-rebreather mask is often thought of as the classic oxygen mask you put on a patient. This is typically used for patients who have severe respiratory distress or hypoxia, where we need to deliver high concentrations of oxygen, concentrations of up to 100%, if you will. This is the preferred way to give oxygen in the pre-hospital setting for those patients who are in need of significant oxygen therapy. Make sure that the reservoir bag is full before placing the mask on the patient. You can do this by attaching the non-rebreather, and you'll practice this in lab. Attaching the non-rebreather to the oxygen regulator, turning the regulator on to at least 12 liters per minute, holding your finger over the flutter valve inside the mask. That will allow the bag of the non-rebreather to fill with air, and then place it on the patient. You want to make sure and adjust your flow rate so the bag doesn't collapse when the patient inhales. This is a reservoir bag for them to inhale from that is 100% oxygen. When oxygen therapy is discontinued, make sure you remove the mask. The next delivery device is the nasal cannula. This delivers oxygen through 2 small tube-like prongs that fit within the nostril. This can provide concentrations between 24 and 44% inspired oxygen when the flow meter is set to a range of 1 to 6 liters per minute. This is the typical chronic supply method for oxygen use in patients. So patients who are on a chronic prescription or using continuous oxygen supply, this is the typical method in which they use. It is used in patients with mild hypoxemia In a patient who breathes through the mouth, though, there can have some problems, or if they have a nasal obstruction, because this is designed to deliver oxygen directly into the nares. If you anticipate a long transport time with these, it's important to consider the use of humidification because the compressed gas is dry. It can dry out the nasal passages, create some discomfort, or potentially light bleeding. We also have some variants of things like partial rebreather masks. These are simple non rebreather masks or similar to non rebreather masks, but there's no one way valve between the mask and the reservoir. So it allows a patient to rebreathe a small amount of exhaled air. Similarly, we have things like Venturi masks. And this is a strategic device that we can set the specific amount of concentration for oxygen to be delivered. So in brittle respiratory patients or respiratory patients that are being weaned off of high concentrations of oxygen, perhaps in discharge from a hospital or recovering from things like ARDS or RSV, may be prescribed a specific percentage of oxygen. This lets us dial that in precisely, and we can deliver ranges from 24 to 40% as long as we change out. You can see the multicolored plastic pieces there that identifies the percentage amount we're going to deliver. We also may need special circumstances masks, such as tracheostomy masks. So when a patient has a tracheostomy, or they have a breathing tube in their throat, not coming out of their mouth, this is long-term. A tracheostomy tube is a long-term process. There are types of masks that can fit over the tracheostomy tube to allow the patient to have inhaled oxygen through their main path of breathing, which is that os, or that tracheostomy tube. You can modify non-rebreather masks as well as simple face masks to achieve the same goal. Just make sure that you don't occlude the end of that tube with any device. So you would never want to place a nasal cannula directly into that breathing port. That port should be left open to the outside environment and provide mass to the ambient air